Good afternoon, and welcome to the 2020 launch of the California ACEs Aware initiative. My name is Tanya Schwartz, and I'm with Harbage Consulting. We are very proud to be supporting the Department of Healthcare Services and the Office of the California Surgeon General on this initiative. I'm going to start with some quick housekeeping items and a sound check. If you can hear me okay, can you please click the raise your hand icon on the right-hand panel? All right, it looks like we are good. If we run into any technical difficulties and get disconnected, please dial back into the webinar using the same link and call-in number, and we'll be with you as soon as we resolve any issues that might come up. We want to let you know that all participants will be muted, but you can submit questions at any time during the presentation using the chat feature on the go-to panel on the right-hand side. And finally, this webinar is being recorded and will be available on acesaware.org. Next slide, please. So we have a great set of speakers lined up today that I'm excited to introduce. We have Dr. Nadine Burke-Harris, the California Surgeon General, Dr. Annalee Amernath, the Medical Program Consultant and Chief of Medi-Cal Managed Care Quality and Oversight at the Department of Healthcare Services, Dr. Melissa Merrick, the President and CEO of Prevent Child Abuse America, and Dr. Bridget McCaw, a clinical advisor to the ACEs Aware initiative. Next slide, please. On today's webinar, we will cover what is happening nationally on ACEs and toxic stress, provide an overview of the ACEs Aware initiative, talk about the biology of adversity and the clinical response, explain the Medi-Cal certification and payment process, and share tools and resources to support providers. And then we'll conclude with your questions. Next slide, please. Our specific objectives for this webinar are to frame how ACEs Aware fits into national efforts, to provide information on ACEs and on the ACEs Aware initiative, to explain the biology of adversity, and to share screening tools, clinical workflows, and algorithms to address ACEs and toxic stress, and to familiarize you with ACEs Aware activities, tools, and resources that are available to support you and your staff in screening for and responding to ACEs and toxic stress. With that, I will turn it over to Dr. Burke-Harris, the California Surgeon General.
Thank you so much, Tanya. And I just want to welcome everyone. Next slide, please. And thank you so much for joining us for this first in a series of webinars on ACEs Aware to support our providers. So today, as you heard, we're going to be really framing the ACEs Aware work that we're doing here in California against the national backdrop. And the thing I'm most excited about, sharing some of the tools, activities, and resources that we've developed for the initiative. And to frame the national perspective is Dr. Melissa Merrick. She's formerly the Senior Epidemiologist for the National Center for Injury and Prevention at the U.S. Centers for Disease Control and Prevention, the CDC, and is now the President and CEO of Prevent Child Abuse America, the nation's oldest nonprofit organization dedicated to the primary prevention of child abuse and neglect. Dr. Merrick has nearly 20 years of clinical research and leadership experience related to the etiology, course, and prevention of adverse childhood experiences, child abuse, and neglect. Dr. Merrick?
Thank you, Dr. Burke-Harris. I am so thrilled to be with you all today to give you a little flavor of what's happening at the national level around ACEs and toxic stress. And I think really we can see on this first slide that really I think we're in the business now in this next generation of work of really preventing ACEs and toxic stress before it begins. So really when we look at a public health definition, it's really what we as a society do collectively to assure the conditions in which all people can be healthy. So this is a very visionary definition, and it takes all of us. We all have a role to play in the prevention of early adversity, and I'm just so thrilled for your new Surgeon General in California. Obviously, Dr. Burke-Harris has been such a leader, even nationally, and that you all have her there in California to lead this work is just so exciting. Next slide. And we can see that as we implement a public health approach, so when we're talking about assuring the conditions, we're talking about these roots, what's here on the pair of ACEs slide to be adverse community environments. I see this as adverse conditions. So maybe as a field, we've really grown to see the leaves of adversity, to see child abuse, child neglect, various forms of household challenges, to understand the prevalence, the burden. We're going to talk a lot about that today and through your entire ACEs Aware initiative. But also taking a public health and a prevention approach requires comprehensive strategies that get at both the root causes, those kinds of isms, poverty, discrimination, racism, income inequality, all of those things at the roots. Because if we change those roots, what are the leaves that we might be able to observe in the next generation? Next slide. But no matter how you really measure ACEs, we know a couple things from this very rich literature. We know that ACEs are common. In any sample, you have at least 60% of people that report at least one ACE. For those of us in this work, we know that often ACEs co-occur. So if you have an ACE score of 1, you're more likely, about 85% more likely, to have additional adversities as well. And not just that they're common, but you see here a summary slide that across 40 plus health outcomes to date, as your early adversity increases there on the horizontal axis, so too does your host for a whole host, or so too does your risk for a whole host of negative health outcomes, like physical health outcomes, obesity, diabetes, obviously mental health outcomes, depression, suicide attempts. Health risk behaviors also increase, things like smoking, alcoholism, opioid use, and misuse. And it also, early adversity impacts our life opportunities. The more adversity we have, the more likely we are to not complete high school, to be unemployed as an adult, and to live in poverty as an adult. Next slide. And although California data even shows more than 5 of the 10 leading causes of death linked to early adversity, CDC in November of 2019 released a vital signs on adverse childhood experiences, and I was fortunate enough to serve as the lead author of that work, where we took data from 25 different states and DC, about 144,000 participants, and we find the same things, right? Where ACEs are very common. 61% of this sample had an ACE score of 1. Much more compelling to me is that 1 in 6 adults, or 16%, experienced 4 or more types of ACEs. And again, as our ACEs increase, so too does our risk for 5 of the 10 leading causes of death from these analyses had roots in early childhood and adverse childhood experiences. But we also saw that preventing ACEs could reduce the number of adults with depression, for example, by as much as 44%. Next slide. This also, across all of the outcomes that we looked at, we found these kinds of reductions in leading causes of health, morbidity, and mortality. So by preventing ACEs, we could prevent up to 21 million cases of depression, up to 1.9 million cases of heart disease, the leading cause of death in this country, and up to 2.5 million cases of overweight or obesity. The good news in all of this work is that ACEs are preventable. They are not destiny. Just as we know that early adverse experiences stay with us across the life course, so too do protective factors or protective experiences that children and families have. Next slide. Which is why the role of public health in violence prevention is really about boosting these protective factors, not just protective relationships, but protective environments, socio-political environments even, and focusing on this left side of this graphic in primary prevention, stopping early adversity and violence before it occurs in the first place, thereby stemming the flow of children and families that touch these other systems like criminal justice, child welfare, even healthcare. And what's so exciting about the work here that we're going to talk about today in California is the stuff that's happening around healthcare providers. There was a really JAMA viewpoint commentary that came out in conjunction with the Vital Signs that has a lot of best practices for healthcare providers, many of which you'll hear from Dr. Burke-Harris are being implemented right now in California. Next slide. And so you can see this next slide, Essentials for Childhood. This is CDC's vision for this work to assure safe, stable, nurturing relationships and environments for all children. So again, very much a public health approach, very much strengths-based. What are we trying to achieve? And not just calling out relationships, but also these broader conditions and contexts that support children and families to reach their maximum health and life potential. Again, CDC, the leading public health agency for our country. Next slide. And you can see that this public health approach is not just so aspirational, in public health organizations, but here you can see this is the shared vision among all of the sister agencies in health and human services for our country, creating the conditions for strong, thriving families and communities where children are free from harm. I had the pleasure of being on a detail with Commissioner Jerry Milner, who leads the Children's Bureau, really where child welfare and our child welfare agency gets its leadership. And again, this shared vision, we're talking about the same children and families around the country. So how can we really set the course for preventing early adversity before it occurs? Next slide. And so CDC has also provided and produced a series of resources. They have technical packages, if you will, that are based on the best evidence-based strategies for preventing child abuse and neglect, youth violence, suicide, intimate partner violence. And here's one of their latest on cross-cutting strategies to prevent ACEs. This is their newest ACE prevention resource that describes these different buckets of strategies. And again, a public health approach requires or calls for a comprehensive approach to prevention, whereby any state, community, organization, et cetera, would have activities in all of these buckets to do true comprehensive prevention work. And so again, you're going to hear today about some great efforts here in California to really do ACEs screening, which of course is embedded in this technical package and others, for having good evidence as a piece of this comprehensive approach to preventing early adversity. Last slide for me is that prevention happens in partnership. This is something that can't be underscored enough. We all have a role to play in assuring health and prosperity for our children and families in this country and around the globe. But this is not just the work of physicians or of government, but also of schools, of business, of media, of nonprofit organizations such as Prevent Child Abuse America. Certainly, Prevent Child Abuse California chapter and the Essentials for Childhood California team are so thrilled to be working in partnership with the Surgeon General and all of the wonderful efforts that are happening in California to really help us understand, what does prevention look like? What can physicians, practitioners, healthcare systems, what can they do to really prioritize prevention? So I'm just so thrilled to hear all the answers by your Surgeon General, Dr. Burke-Harris. I'll turn it back to you, Nadine.
Thank you so much, Dr. Merrick. Next slide, please. So as we think about prevention and what does that look like in terms of a broad public health agenda, but also in terms of what it looks like on the ground in terms of the difference of what we do. I think that I tell the joke that when I saw the CDC report with the vital signs report that came out in November, where ACEs were featured in the Morbidity and Mortality Weekly Report, I felt like it was like the cover of Vogue, right, for this work, which was really joyful. And when we think about what a true public health approach looks like, we want to focus on primary, secondary, and tertiary prevention. Primary prevention being addressing those systemic and structural barriers, raising awareness, and really transforming those conditions. But also we recognize that what the evidence shows is that early detection and early intervention improves outcomes. So here in California, ACEs Aware is also focused on systematically deploying broad-scale screening to enable early detection and evidence-based intervention on ACEs and toxic stress. When we look at working in partnership and thinking about what that really means, the question is, what is the role that we each have to play? And our primary care providers here in California have a very important role to play in terms of doing that early detection and evidence-based intervention to support patients and families. We're focused on interrupting the vertical transmission of ACEs by advancing screening not only in children, but also in adults, with special focus on the prenatal and early parenting years, coordinating and strengthening the network of referral and response to make it more effective, accountable, and easy to navigate for patients, families, and providers. And finally, advancing the science of toxic stress to improve the efficacy of our interventions and identify potential therapeutic targets. Next slide, please. So as we move forward grounding in this work, we recognize that for ACEs Aware, we identify the 10 traditional categories of ACEs from the Adverse Childhood Experiences study that you see on the screen in front of you. I won't go through them one by one, but we stick to the traditional categories to help us to be able to make scientifically valid comparisons in terms of relative risk of health conditions. We also recognize at the same time, as we heard from Dr. Merrick, that the adverse childhood experiences, the factors that were identified in the adverse childhood experiences study are not the only risk factors for toxic stress. So we want to also recognize that other factors like poverty, like discrimination, are also risk factors for toxic stress, and understand how we can address those social determinants. Next slide, please. What we see in the data here in California is that similar to what Dr. Merrick described with the national CDC data, 62.7% of Californians have experienced at least one ACE, and 17.6% of Californians have experienced 4 or more ACEs. So for most of us clinicians, that means that every day we are seeing individuals, families, patients who have experienced significant ACEs. And so our ability to be part of that network of response is really critical. Next slide, please. And as Dr. Merrick mentioned, in our analysis for the ACEs Aware work, we looked at not only the CDC data sets, we drew from the CDC data sets, and we also drew from global meta-analyses around the impacts of ACEs, and looking at large, robust data sets from around the world. What we see is that there is this strong association between ACEs and 9 out of 10 of the leading causes of death in the U.S. So really, there is an important healthcare imperative to be doing that prevention, early detection, and early intervention that the evidence shows improves outcomes. Next slide, please. And in addition to this medical and ethical imperative, we also recognize that there is an economic imperative. In California, the annual cost to California of ACEs just for these 8 health conditions is $112.5 billion per year. That's over $1 trillion in 10 years. So really, we recognize that as a way of improving our healthcare utilization and an ounce of prevention, or I will say a penny of prevention is better than $1 of cure. And the reason this is so important is because what the research shows us, next slide, is that ACEs are not destiny, and that with early detection and evidence-based intervention, we can transform health outcomes. And one of the important ways that we can do that, next slide, is really by recognizing that when we look at other public health advances, whether it was the understanding of germ theory to develop everything from antibiotics to vaccines, or whether it was the understanding of transmission of factors like HIV/AIDS that allowed us to be able to develop antiretrovirals, understanding the biology of adversity is very important, not only in terms of understanding what the risks are to our patients, but also to strategize and deploy thoughtful responses. Next slide, please. And what the biology tells us is that our stress response, we know, falls in along a spectrum of 3 different types of stress responses. We know that there's the positive stress response, which is brief activation of the stress response, brief elevations in heart rate, blood pressure, and hormonal levels, but that homeostasis recovers through our body's natural coping mechanisms. Now, when the stressor is more significant and more intense, the body can tip into the tolerable stress response, which is a more prolonged activation of the stress response system and systemic changes, but that through the buffering effect of caring adults and other interventions, that homeostasis can recover. But when that those buffering caring interventions are absent or inadequate, what we see as a result is the toxic stress response, long-term changes in the brain and body as a result of prolonged activation of the biological stress response, the lack of the normal feedback inhibition or the ability of the stress response to turn itself off normally, which leads to stress-related disease and cognitive impairment. And so it's important to recognize that when we're talking about the toxic stress response, when we're talking about toxic stress, one of the common misconceptions is that folks talk about toxic stress in the context of the stressor, right? And we recognize that toxic stress is actually one of the 3 characterizations of the physiologic stress response, either the positive stress response, the tolerable stress response, or the toxic stress response. And that is the maladaptive stress response. Next slide, please. And so the ACEs Aware initiative, being led by my office and the California Department of Healthcare Services, is really focused on offering Medi-Cal providers training, clinical protocols, and payment to be able to screen children and adults so that we can detect ACEs early and connect patients to the resources and interventions that can improve their health. Next slide. So we're really excited to share with you, and for those of you who have already gone on the acesaware.org website, you'll see that we have a number of clinical tools and clinical workflows. The tools and workflows that I'm about to describe are available both for pediatrics and for adults. So I'll just quickly review. We talked about this. We touched on this a little bit in our last webinar as well. But we have the clinical workflow developed by the Clinical Advisory Subcommittee, a team of experts with extensive expertise on ACEs and toxic stress and the clinical screening and intervention. And so the clinical workflow really helps a clinic be able to understand how they're going to screen? What are the roles that each member of the clinic team will play? What the registration or front desk staff will do? Sharing the tool with the patient or the caregiver, if it's a pediatric patient, as we see here with a pediatric workflow, and it just walks folks through each step, kind of like the clinical workflows that we would see for other common clinical implementations, such as lead screening or hemoglobin. Right? It's a simple clinical workflow. Next step. And for the pediatric screening tool, ACEs Aware, the Department of Healthcare Services, will reimburse for the use of the PEARLS tool. That's the Pediatric ACEs and Related Life Events Screener. And what you'll see is that there are two parts to the PEARLS tool. One is ask questions about ACEs, and part two, ask questions about other social determinants of health that we recognize may also be risk factors for a toxic stress response. But it's important to note that these two sections are scored separately and that they should not be combined into one score. It should be a separate ACE score and then the related life events score, simply because we don't want to confound what that number is in terms of our risk for health conditions. Next slide, please. And the screening tool, as we've mentioned before, is available in both the de-identified, which was in which parents or caregivers or the patient, if it's an adult, does not say which ACEs they've experienced, only how many. And in some clinical pilots and in early research, the findings are that this may be associated with greater patient comfort. And there's also the identified tool in which the respondent can say exactly which ACEs they have experienced. So both are available. We have not made any specific recommendations on which to use, only share the information that there's early data saying patients may be more comfortable with a de-identified screen. And then we've made available on the website as well the ACEs and toxic stress risk assessment algorithm. It's important to recognize with this that the ACE score, right, tells us the ACE score used in combination with an assessment for ACE-associated health conditions can give an indication to the clinical provider as to whether the patient is at low risk, intermediate risk, or high risk for experiencing a toxic stress response. And so you'll see there's clear guidance with the ACEs and toxic stress risk assessment algorithm on having the ACE screen, which is the part one of the PEARLS, or the total number for the adult tool, assessing for ACE-associated health conditions, and then determining response and follow-up. Next slide, please. I'm so proud of our team has pulled together scoured the literature to pull together the list of ACE-associated health conditions, which is available for pediatrics and adults with conditions, not only listing the conditions of ACE-associated health conditions, but also sharing the odds ratio as how many more times a patient is likely to have this condition if they have 4 or more ACEs. Next slide, please. And what we see is that the benefits of screening are, number one, to determine the likelihood that a patient's health is at risk due to a toxic stress response, right? To better identify ACE-associated health conditions. I think many of us recognize that if a patient is experiencing depression or substance use, that might be related to their ACEs or related to an overactive stress response. But when it's something like asthma or urticaria, it's often less recognized. So having that list of ACE-associated health conditions is very helpful. And then identifying which patients may be at greater risk of transmission of ACEs and toxic stress, right? And targeting our prevention efforts, as well as empowering patients to achieve better health and address their toxic stress physiology. And so, next slide, please. What that looks like clinically is, for example, and as we are moving forward with this series of webinars, educational webinars for our providers, we will, later on down the line, you'll see we'll be having specific webinars on doing a deep dive on screening, doing a deep dive on treatment planning. We'll have a deep dive on trauma-informed care. But just looking at what that looks like in clinic. And I think a great example of this, for me, I recall a patient that I had in clinic who was a 16-year-old boy who had a regular physical. The ACE screening was a routine part of his care, and his ACE score turned out to be 6. And he did not have any ACE-associated health conditions, but really applying those principles of trauma-informed care, establishing that trust, the relationship, the collaborative decision-making, and then helping patients to understand that they may be at greater risk because of their history of exposure to ACEs, and what they can do, more importantly, what they can do about it. So I want to give an example of what that looks like. Next slide, please. By sharing another tool that's available on the ACEs Aware website, which is available for pediatrics and also a separate tool available for adults, the self-care tool. So one of the ways that, as a clinician identifies that a patient may be at greater risk, there are tools available to say, okay, looking at the domains of sleep, exercise, nutrition, mindfulness, mental health, and healthy relationships that are demonstrated to reduce stress hormones, reduce inflammation, and enhance neuroplasticity, right, which is essentially counteracting the toxic stress response. Here we see a patient self-care tool that a provider can share with a brief overview as to what ACEs are, how they affect health, right? So, and to help the patient and provider to be able to collaboratively plan and set goals in each of these domains so that they can follow up on this treatment plan as they go forward with the patient's care. Next slide, please. We've also included references in ACEs Aware with patient educational materials. So thank you to the community of providers, researchers, and practitioners who have shared your educational materials. We've taken some of the really strongest and most rigorously scientifically vetted of these materials and made them available on ACEs Aware. And this is an example of a handout that a provider can share with a patient about how to talk, that, just as you would for a patient who has pneumonia and they get that patient handout saying, what are the next steps and what should they look out for. Similarly, we've made available patient education materials on the ACEs Aware website for clinicians to be able to use. Next slide, please. So finally, I want to encourage all providers to go to acesaware.org and hit that button that says Get Trained, and you'll have the opportunity to take the 2-hour provider training that walks through clinical vignettes on screening for ACEs and responding to trauma-informed care. The 2-hour free online course offers CME and maintenance of certifications. And once July 1st rolls around, providers will have to have attested that they've completed this training. Providers won't be able to get paid unless they've completed this training. So we're really excited. Additional trainings will be made available throughout the year, and we are looking forward to engaging our network of excellent clinicians who have been doing this work from around the state and around the country, and providing more resources and tools to you all who are the ones doing the hard work to ensure that California as a state is ACEs aware. And so I would like to turn it over to Dr. Amarnath to talk about the Medi-Cal certification process.
Hi, thank you, Dr. Burke-Harris. I'm Annalee Amarnath, and I'm a family physician and a medical program consultant working with the Department of Healthcare Services. And I'm going to talk a little bit about how providers can complete ACEs screening and receive reimbursement through Medi-Cal. So as of January 1st, 2020, providers who complete qualifying screenings for our Medi-Cal members may receive reimbursement if all the requirements are met. As of July 1st of this year, 2020, as Dr. Burke-Harris noted, providers will have to have completed a certified training and attest to the certified training to continue to receive the reimbursement. In fee-for-service, the reimbursement for eligible providers is up to $29 for each qualifying screening, subject to Medi-Cal policy. In Medi-Cal managed care, the reimbursement for network providers is no less than $29 for each qualifying ACEs screening. Now, a qualifying ACEs screening is one that's done utilizing one of the two required tools. Dr. Burke-Harris talked a bit about the PEARLS tool already, as well as the ACEs assessment tool. Additionally, in order to receive payment, providers must document in the medical record what tool was used, that the completed screen was reviewed, the results of the screening, the interpretation of the results, what they discussed with the individual or the individual family, as well as any appropriate actions that were taken. This documentation must be maintained in the medical record and be made available upon request. But in order to receive payment, providers must utilize one of two HCPCS codes, which are based on the score from the screening. So the first code is G9919, which is for an ACEs score of 4 or greater, and the other code is G9920 for an ACEs score of less than 4, so 0 to 3. Next slide. Now, we have been receiving a number of questions about how to conduct the screenings and what the policy and operational processes are for reimbursement. And we want to recommend that you visit the ACEs Aware website, in particular the frequently asked questions section of the website. Not only does it have contact information where you can send in a question if you don't already see the answer to your question, but there are a number of frequently answered questions that have been put on the website, and these are continually updated. So we encourage you to keep checking back on this website to see if your questions have been answered. Next slide, please. So as Dr. Burke-Harris noted, there are specific tools that are required to be used in order to be eligible for the reimbursement in Medi-Cal. The first tool is the Pediatric ACEs and Related Life Event Screener tool, or the PEARLS tool. There are 3 different tools used depending on the individual's age, as well as who is completing the tool, whether it's the child or the caregiver, and also the identified and de-identified versions. In addition, for adults up to the age of 65, the required tool is the ACEs assessment tool. This would be the tool that was adopted from the Kaiser Permanente and CDC prevention study. Alternative tools are allowed to be used as long as they contain the 10 original categories of ACEs. For example, the first part of the PEARLS tool that Dr. Burke-Harris showed does incorporate those 10 original categories, and that would be a version that could be used. Next slide. So screening for ACEs is voluntary, and also screening can be done by providers as frequently as they deem appropriate and medically necessary. However, for purposes of receiving the reimbursement, there are limitations on how frequently Medi-Cal will provide reimbursement for those screenings. So for individuals under the age of 21, reimbursement for a qualifying screening will be provided not more than once per year per provider, and if it's applicable, per managed care plan, as some Medi-Cal members are in managed care. For individuals age 21 up to 65, an individual may be screened once in their adult lifetime per provider, and again, per managed care plan if applicable. So conducting the screening is voluntary, but providers who conduct a screening, a qualifying screening that meets all the requirements, will receive payment as of January 1st, 2020. As of July 1st, 2020, to continue to receive payment, providers must have completed one of the certified trainings and completed the self-attestation for that training. Additional information is available online regarding the Medi-Cal policies through the All Plan letter, as well as the ACEs Aware website, specifically the frequently asked questions section as well. And with that, I'll be turning it over to Dr. McCow.
Well, thank you very much, Dr. Amarnath. I'm Bridget McCaw, clinical advisor for the ACE Aware Initiative and internal medicine trained physician. I'm delighted to be able to show you some of the resources that have been developed to support the ACEs Aware Initiative. Next slide, please. We have a variety of activities underway to engage and support providers so we can ensure that you have the information, tools, and resources you need to feel confident in caring for your patients. Here are 3 examples. Today's webinar is the first in a series focusing on practical information to help providers integrate screening and response to ACEs and toxic stress into their clinic workflow. A second example was the request for proposals that was issued to fund organizations to help extend the reach and impact of ACEs Aware, and those applications are currently being reviewed. And the third example is a very exciting endeavor, the California ACEs Learning and Quality Improvement Collaborative, CalCIC, which is a statewide learning collaborative of pediatric and adult clinics to help identify promising practices and partnerships and inform future phases of the ACEs Aware initiative. Now we're going to move from the slide presentation to a live demo of the ACEs Aware website. And over the next 5 to 6 minutes, I'll give you a brief tour of the kinds of tools and resources that Dr. Nadine Burke-Harris and Dr. Amarnath referred to that you can find. And a thank you to Terry Velos, who will be our navigator. So if we start with the ACEs Aware website landing page, you can notice the categories at the top that say Screen, Treat, Heal, and About. As you hover over each category, you'll see the types of information that you can refer to there. Let's go to the drop down on the Screening category called Screening Tools. This is the page where you can find the Pearls and Adult Screening Tools that Dr. Burke-Harris and Dr. Amarnath referred to. If you scroll down, you can see the listing here. These are the approved ACE screening tools that Medi-Cal providers can use for the Department of Healthcare Services payments. And as you can see, there are different versions. And on the left, you can note that it says child or teen, and that helps guide the provider to select the one that's appropriate for their patients. Notice that you can also distinguish the format of the screening tool because it says on the right, de-identified or identified, and we saw an example of the de-identified Pearls screener through Dr. Burke-Harris's presentation. The Department of Healthcare Services is working currently to translate the Pearls tool into several languages, and once those translations are completed, these versions will be posted on the page. If you scroll down to the adult screening tool, you can see that that is already available in English and Spanish. And if we go ahead and open up the de-identified adult ACEs screener, you can see what this looks like, and then scrolling down to the bottom, you can see that in this version, the de-identified version, the patient does not indicate which specific adverse experiences have occurred, but just total how many. Let's go back to the drop-down selections for screening, and this time we'll select provider training. And if you scroll down a little bit here, you can see more information about how the online training that Dr. Burke-Harris referred to is really phase one of what we anticipate we'll be able to offer to providers. If you go here, you can either click on the Get Trained, or you can do the orange button that says Get Trained, and that's the way in which you can go in, set up an account, and get registered and take the training. But there's more coming. Looking at this for a moment, what you would do is you would go to create an account. We won't click on that now, but it's the place in which you start your account. And it's important to note that it's fairly straightforward to navigate this, but if you have handy your national provider identification number and any board certification ID number if you want to get maintenance of certification credit, this makes it a lot easier to go forward and create the account and begin doing the training. Let's go back to the ACEs Aware main site and go to screen once again. And notice at the very bottom is certification and payment. We're not going to click that now. I just wanted to show you where it is since Dr. Abernath referred to it. Let's move over to treat. And the drop downs here include the science of ACEs and toxic stress, principles of trauma-informed care, and clinical assessment and treatment planning. Let's look at clinical assessment and treatment planning, because this is where you can find the pediatric and adult ACE screening clinical algorithms that we saw earlier. There's a link here at the very beginning, and there is also a resource box at the very bottom of this page that allows you to access these resources and have them readily available in clinic. If we scroll up just a little bit, I want to highlight that one of the slides that we saw in the presentation, which is so important, which is how do we intervene and respond when ACEs are identified, is right here on this page as a reminder for what it is that we want to do. Let's move over to the HEAL category and look at resources. On this page, you can see links to many kinds of information, including the kind of patient education that we saw highlighted earlier. There's also clinical tips, providing trauma-informed care, reference materials for the Center for Youth Wellness, the American Academy of Pediatrics, the CDC, and other organizations. But one caveat, this website, acesaware.org, is only 2 months old, and we're actively working on improving the site overall, and in particular, reorganizing this page and making improvements so that it will be much easier to navigate to all of our resources and information. So we appreciate in advance your patience during this process. Please know that the next time you come to the page, it may be a little bit different in its appearance, but we expect it to be easier to navigate. And if you have a resource that you think we should know about, please send it to info@acesaware.org. Let's look at the other drop-down under HEAL. Educational events. This is a page that you'll want to check periodically. It's where you can learn about and register for upcoming webinars that are sponsored by the Office of the Surgeon General and the Department of Healthcare Services. As mentioned, today was the first one that we've formally done, but you'll see that we have several others planned for the rest of the spring and early summer. All of the webinars are recorded and they get posted to this website so you can watch the recording if you're not able to attend at the time that it's being given. Now let's go up to About. And here is a place where you can find the policy guidance that Dr. Abernath mentioned. And also, let's go down to Materials for Partners. And if we scroll down a little bit, I want to point out 3 fact sheets that are really handy to know about and to be able to share with partners, with other people in the clinic, or folks that want to know more about the initiative or the science of trauma and toxic stress. One other addition that's brand new to this website, as of just yesterday, is a general search function. And this allows you to navigate this site, and it makes it much easier to find and get the information you want. We are going to continue to enhance this website so that it will serve all of you who are serving patients as well as possible. And now let's return to the regular slide presentation. Coming soon is another tool, which is called the Provider Toolkit. And this is designed to be a series of online fact sheets that support Screen, Treat, and Heal. They can be read individually and used as part of training efforts or as reminders or as references. They're written to be concise and easily readable. They'll be available online, and we expect to have this available later this spring. So I'll now turn this over to my colleague, Tanya Schwartz.
Great. Thank you, Dr. McCaw. Next slide, please. So as Dr. Burke-Harris and Dr. McCaw mentioned, this is the first of a series of educational webinars that will provide practical information to help providers integrate ACE screening and response into their clinic and workflows. You've already seen on the website, we have 4 webinars scheduled. We hope you will continue to join us for lunch on the last Wednesday of each month. Please go to the website to register for these deep dive webinars on trauma-informed care, building resilience in the workforce, screening and responding to ACEs for pediatric patients as well as for adult patients. Next slide, please. Again, the training, information, materials, frequently asked questions are all on acesaware.org. The recording of today's webinar and the slide deck will also be posted there, so please check back frequently. We're continuing to add information. And so that concludes our presentation, and it looks like we have about 5 minutes for questions. Samantha, can you please share the first question?
Great, yes. This question is for Dr. Burke-Harris. With the pediatric risk assessment, in your experience, has it been found that parents disclose potentially sensitive information?
Sometimes that does happen. Yes. So, in my experience, what we've experienced both in my clinical practice and in the Pearls research study is that it's uncommon that parents for the first time de novo disclose active abuse or neglect that has never been mentioned before. But it does happen. And oftentimes in those situations where it does happen, I think that it's really, what we find is that parents are grateful to understand that ACEs can be affecting their children's health in that way. In those situations, we want to utilize the resources that we have in clinic to either connect the patient to a social worker or a mental health professional who can then facilitate or help with that process. Or if that individual is not available, we would follow the same protocol that we do in any other disclosure of sensitive information.
Great. Another question that we received, also for Dr. Burke-Harris, asked, does ACEs increase risk of depression, poor coping skills, and lack of support?
Yes. Yes, what we see from the original ACE study, we saw that for individuals who had 4 or more ACEs, they were about 4.5 times as likely to be diagnosed with depression.
Okay, another question we received asked, what other tools and resources is ACEs Aware planning to develop to support providers and their staff in treating patients with high ACEs scores, such as those with 4 or more ACEs?
So I'll go ahead and take that question. So one of the things that we're doing as part of ACEs Aware is that we're receiving a lot of the feedback that you all have shared. So I want to say a huge thanks to the providers who have gone through and taken the 2-hour online training, and let everyone know that we are reading your comments and questions that are shared with that process. And our process has been to bring those questions and comments together. And as we're looking at them, to see which are the issues that are rising to the top as areas that providers most urgently or most consistently express a need for additional support. In addition, through our RFP process, some of the things that we've been doing, for example, we've heard a request, a need, and a desire for training materials for other staff members other than the primary care provider, which is what the 2-hour training is more focused on, the primary care provider. So how do we look at training materials for other members of the clinical team? And so that was one of the things that was encouraged as part of the RFP process, and we're still looking at all of the proposals that have come in. So we have essentially, you all as the community are helping to inform us as to the tools that you generate, and then also what tools we're hearing from you that you need.
Great. Thank you, Dr. Burke-Harris. And so we are just about at time, so I want to thank you all for joining. Please visit acesaware.org, and we hope to see you at the next webinar on March 25th. Thank you all. Have a great rest of your day.